regarding paroxysmal nocturnal hemoglobinuria. It is due to a mutation in the PIGA gene leading to the absence of GPA proteins. As a result, the GPA protein cannot bind CD55 and CD59. These CD55 and 59 protects the RBC from complement. So, when CD55 and 59 are lost due to defect in the GPA, they are susceptible to attack by the membrane attack complex complement. The hemolysis in paroxysmal nocturnal hemoglobinuria is purely intravascular due to complement mediated destruction, and the triad of hemolysis plus pancytopenia plus thrombosis makes the diagnosis of PNH very likely. Coming to the pathophysiology, as we said earlier, it is due to a mutation in the GPA, and hence the GPA linked proteins CD55 and 59 are unable to bind to the RBC. Therefore, they get susceptible to the destruction by complements, of which CD59 is the most important one. And this CD59 absence in the platelet causes its inappropriate activation, thereby leading to thrombosis. Clinical features: patient mostly presents to us with painless hematuria, that is dark color passing of fresh blood in the early morning, and hematuria typically gets aggravated during infections. It can be either viral or bacterial, and patient may sometimes present to us with complications of anemia, and abdominal pain can be due to thrombosis of the intra-abdominal vasculatures, and Buchier syndrome can also be one of the presentation of PNH. Cause of death: it is mostly due to thrombosis. That too venous thrombosis can produce death. The other causes for death are neutropenia related infections. Rarely this PNH can get transformed into AML. Investigation: the patient will be having normocytic normochromic anemia. Patient will be having elevated LDH and decreased heart globin, typical of hemolytic anemia. And the following tests are used to diagnose PNH. One is sucrose hemolysis test, another one is Ham's test, and other one is the gold standard one, that is flow cytometry, which is the gold standard for diagnosing PNH. Management: you can manage previously the patients were managed with bone marrow transplant, but recently a drug called eculizumab is used, which binds to C5, that is complement factor 5, and thereby the decreased activation of the membrane attack complex C5 to 9. Hence the RBCs are protected from intravascular hemolysis, but remember, still the RBC can bind to C3, that is complement factor 3, and can get opsonized and destroyed in the extravascular compartment. As usual, for any hemolytic anemia, iron and folic acid supplementation are given, and steroids can be used when the underlying hemolysis is getting aggravated due to any underlying inflammation in the form of any infections under cover of antibiotics. And thromboprophylaxis for lifelong has to be given if the patient has developed some form of thrombosis.